Hello, everyone. Welcome to the webinar series for the Autism Intervention Research Network on Physical Health, the AIRP. My name is Keisha Rosenau, and I'm a developmental researcher at UCLA and a project scientist on the AIRP. I want to thank all of you for joining us today. Before we begin, I would like to address a few logistical details. I will provide a brief introduction for our speaker, and we will also reserve time to answer questions at the end of the presentation. Because of the number of participants, your audio will be muted throughout the call. However, you can submit questions at any point during the presentation via the chat box on your webinar console. This entire webinar is being recorded and will be available on the AIRP website, airpnetwork.ucla.edu. There will also be a short evaluation survey at the close of the webinar. We invite you to provide feedback on this webinar and also to provide suggestions for future webinars, as we appreciate feedback on the content of the monthly webinars hosted by the AIRP. In the interest of time, let's get started. So first, we want to acknowledge our funding source. And now it is my honor to introduce the principal investigator and director of the AIRP, Dr. Alice Kuo. Dr. Kuo is a professor and chief of medicine pediatrics at UCLA and the director of the UCLN program. Please join me in welcoming Dr. Kuo.
Thank you so much for having me. Let's get started because we have a lot to cover. So as we know, we are still going into the 12th month of a global pandemic. The COVID-19 condition is caused by the SARS-CoV-2 virus, which was first discovered in Wuhan, China in December of 2019. The WHO, the World Health Organization, declared the global pandemic on March 11th, 2020. It's hard to believe that it's been that long ago. As of today, there are over 109 million cases worldwide and over 2.41 million deaths. So what is the best response during a global pandemic? For all of us, for many of us, this is the first major global pandemic that we've been through. I want to credit the UCLA Health marketing team for putting together some of these slides. And so they are California specific or even Los Angeles. But during a pandemic, the best response is to follow the guidance of our public health officials. Nationally, this is the Centers for Disease Control and Prevention, and then your state or local public health department. What we have learned over the course of the last year in managing our pandemic is to wear universal masks, keep physical distance or social distancing, wash hands frequently, wipe downs of high touch areas, and then symptom screening, meaning that if you are sick or have any symptoms, you should not leave your home. A vaccine is a valuable tool for fighting a pandemic. And so with the news of the COVID-19 vaccine a couple of months ago, we now have a valuable tool to finally end this pandemic. The benefits of a vaccine is that with herd immunity, we can protect those among our community who cannot be vaccinated. How does the body fight an infection? In order to understand how a vaccine works, we need to understand how our immune system works. So just like other systems in our body, our immune system is there to protect our total body against germs, which can comprise of either bacteria or viruses. The COVID-19 condition is caused by a virus. So the immune system is stimulated to produce antibodies, and I liken these antibodies to soldier cells. These are the cells that will help fight the infection and neutralize any germ from causing illness in your body. The way the vaccines work is that they contain a code or a protein that stimulates the immune system to produce a particular antibody in order to fight the bacteria or virus effectively. How were the COVID-19 vaccines shown to be effective? I just want to emphasize that these vaccines have been approved by our Food and Drug Administration, which is a regulatory body for all medications and drugs or injections in the United States. So in order for a new medication or vaccine to be approved, there are 3 phases of clinical trials. Phase 1 comprises of about 20 to 100 healthy volunteers, and the main focus of phase 1 is to know whether the vaccine is safe. We entered phase 1 for the COVID-19 vaccines in early summer of last year. In phase 2, there were several hundred volunteers that started looking at the common side effects, as well as the actual immune response to the vaccine. And this was around June and July of 2020. Phase 3 comprises of thousands of volunteers. And for each of the FDA approved vaccines, about 16 to 20,000 volunteers were used to determine the effectiveness of the vaccine. This is the most important phase of the clinical trial. This clinical trial, phase 3, went from July 29th of 2020 into the fall, and around November, there were sufficient data to submit to the FDA for emergency use authorization. The FDA went through its complete regulatory process, and the FDA will only license the vaccine if it's safe and effective and the benefits outweigh the risks. To date, right now, there are 2 COVID-19 vaccines that have been authorized for emergency use by the FDA. The Pfizer-BioNTech one and the Moderna. And these names are the names of the pharmaceutical companies that produced the vaccine. They both were approved relatively at the same time in the middle of December. The Pfizer vaccine is approved for individuals as young as 16 years of age because there were 16 and 17-year-olds in the clinical trials. And the Moderna was approved for only adults, 18 and above. Both of these vaccines require 2 doses. For Pfizer is 21 days apart, for Moderna is 28 days apart. The vaccine is administered as an injection into the muscle. And so basically, if you go to the edge of your collarbone, the top of your shoulder, and you feel the hard bone, you take 2 finger breaths below that, and that will get you right at the belly of the deltoid muscle in either arm. And just to note, you must receive at this time the same vaccine for both doses. If you start with the Pfizer vaccine, the second dose must be Pfizer. If you start with the Moderna vaccine, the second dose must be Moderna. You cannot mix or match. How effective is a COVID-19 vaccine? It is extremely effective. Based on the data from the clinical trials, it is 95% effective after the second dose. People have asked, and this is a common question, how effective is it after the first dose? I've asked my infectious diseases colleagues, and they have said that the Pfizer dose is about maybe 50% effective after the first dose, and Moderna is 80 to 85% effective after the first dose. However, after receiving the second dose, which is a booster, then both are 95% effective, and a person is considered immune to COVID-19 2 weeks after receiving the second dose. How does the COVID-19 vaccine work? Well, we know that COVID-19 is caused by a coronavirus, and corona means crown in Latin. So if you see in the diagram, the blue coronavirus looks like a crown because there's a circle, and then there's pins, like the spiky things surrounding the crown, surrounding the circle. So that is the virus, and if you are exposed to the virus, meaning that the virus enters your body through one of your mucous membranes, then you have a likelihood of getting sick from it. The way that works is that the virus then will bind to a receptor on one of your cells. The receptor is the little Y on the bottom, and you can imagine how that spiky knob would go into the Y, the cup part of the receptor. And once it locks in, the receptor then draws the virus into the cell, and then you have the likelihood to get sick because the virus can then replicate. The way that a vaccine works is that it stimulates your immune system to produce antibodies, those soldier cells that I was talking about. So the antibodies are depicted by these yellow Ys. And the Y is because of the shape of the protein. What happens is those antibodies bind the spiky parts all around the virus. And so once it's covered with antibodies, when the virus comes near one of your receptors on the cell, it can't get into the cup. It can't lock in. The antibody blocks that receptor binding. And so the virus is neutralized in your body and can't get you sick. Is it better to get vaccinated or contract the the disease naturally? This is a common question, and it is better to get vaccinated. What the scientists have seen is that the immune response, the levels of antibodies, are much greater with the vaccine than with people who just get the virus, contract the virus naturally, and then get over the illness. And so what the new technology that is with this vaccine is mRNA. And this mRNA is a very effective code to instruct your immune system to produce the exact antibody that is needed to bind the SARS-CoV-2 virus. And not only does it produce the right antibody, but in lots of quantity. So you can imagine if you have a lot of virus that you've been exposed to, you need a big antibody response in order to neutralize all of those viruses. And so the definitive answer is that it is better to get vaccinated. Why get the vaccine if most people don't die from COVID-19? Well, as of February this month, COVID-19 has killed more than 485,000 people in the US. And this is more than any other virus that we routinely vaccinate against, like influenza. And so this vaccine is needed, number one, as a long-term strategy to end the pandemic, but to protect ourselves from any complications if we were to contract COVID-19, and to also protect those amongst us in our communities that cannot get vaccinated. What is the vaccine distribution plan? So you may have heard this has been in the news a lot lately, and the CDC has recommended a tiered approach in order to determine how the vaccine will be distributed, because we currently have such a severe vaccine shortage in the US. And so this is, I'm sure that every community has some sort of prioritization scheme very similar to this one. This one just happens to be the one we're using in Los Angeles County. But the first group to be vaccinated were our healthcare workers, which are the frontline, defense in the hospital, treating and taking care of patients. And so healthcare workers needed to be vaccinated. And those at highest risk of death from COVID-19, which were nursing home residents. So those were the biggest priority in Los Angeles County. And now we're sort of getting into other groups. And so a large percentage, about 85% of those in our hospitals and who have died from COVID-19 are individuals over the age of 61. And so for that reason, senior citizens were prioritized next. There's a recognition that essential workers need to be prioritized because they're at greatest risk for contracting COVID-19. And then individuals who have chronic illnesses or medical condition or are developmental disability are prioritized next. And so these are the prioritization categories before the general public. So we're here right now with a limited supply. We're sort of limited to additional. So in many parts of the country, we have moved on to other priority groups. At least I can only speak to Los Angeles County. In the last 2 to 3 weeks, we started doing senior citizens. So we're still very early in the vaccine distribution plan before we can offer it to the general population. My understanding from the pharmaceutical companies is that they are capable of manufacturing about 12 million doses a week. And so as of today in the US, about 53 million doses have been administered. But remember, we have 331 million people in the country. Because it's a 2-dose vaccine, the 53 million doses is sort of mixed between whether they were first or second doses. 11% have received their first dose, and only about 4% of our country has been fully immunized. And so in order to reach herd immunity, the scientists are predicting anywhere from 70 to 80, 85% of the population need to have been immunized. And so we're a little bit of a ways from that, but it's a great start. Other countries such as the UK and Israel are much further ahead. So turning to the populations that we care for, in December 2020, the Committee on Immunization Practices COVID-19 Vaccine Working Group issued these recommendations that are on the CDC website for prioritizing. And the vast majority of individuals with intellectual or developmental disabilities were absent from these priority guidelines. If you go to the CDC website under certain medical conditions that should be prioritized, Down syndrome is listed, but that is the only one. IDD populations are at risk because early evidence suggests that the IDD population is disproportionately susceptible to COVID-19. These individuals in these populations have more severe illness, are at greater risk for hospitalization, have twice the fatality rates, and they also may have difficulty with masking or following social distancing guidelines. And so because of these reasons, it would seem prudent to prioritize IDD populations beyond just Down syndrome for the COVID-19 vaccine. When we look historically, the health outcomes for IDD populations have always been challenging. This population has historically grappled with fragmented access to preventive care and primary care, and that is probably at the root of a lot of the challenges that they face for their health. There's also been historic social and medical stigma and marginalization that continues to this day. And there's a higher prevalence of co-occurring medical, physical or mental health conditions, which may affect their other chronic conditions. And if you have the sort of intersection of IDD and other minority groups, such as racial and ethnic minorities, the conditions, their outcomes can be even worse. So we became very concerned in ARP that the exclusion of IDD populations on the certain medical conditions list of the CDC for vaccine prioritization represented yet another barrier to this population that would have significant health consequences. So we anticipate that this will have challenges for the vaccine rollout, and we really wanted to join the effort to prioritize IDD populations for the COVID-19 vaccine because it seems as though advocacy is needed, as with other groups that are concerned with not being prioritized for the vaccine. And so I just wanted to say that the advocacy has been pretty impressive. I just Googled disabilities and COVID-19 vaccine, and this is what came up on Google. And so this was just even in the last, days to weeks, a lot of awareness being raised locally in order to change guidelines and to include IDD populations in a prioritization for the COVID-19 vaccine. In ARP, we wrote our own commentary, so I wanted to give a shout out to Emily Hotez, one of our, a member of our leadership team, one of our scientists, for lead authoring this commentary that was recently published in a journal of the Lancet. So this is a very concise sort of analysis of why the IDD population should be prioritized. And we are hoping, and we are hearing from disability advocates around the country that they're also penning similar commentaries to be placing in scientific journals, because we need to raise awareness so that the conditions can be changed and the general IDD population can be included other than Down syndrome. In addition to Down syndrome, I would say. So once the vaccine becomes available, we want to make sure that all IDD or populations receive the vaccine. And the challenge, I think, is that there is a fair amount of vaccine hesitancy in our country. So vaccine hesitancy refers to a delay in the acceptance or refusal of vaccines despite having access to vaccine services. And it's very difficult to just say what one thing causes vaccine hesitancy. It's a complex issue and it's context specific. As a primary care provider, I can tell you that I have patients who will, who are willing to get the COVID-19 vaccine, but not influenza. So sometimes, it can be very varying across time and place and the nature of the vaccine. And it's influenced by factors such as complacency, convenience, and confidence, right? So for example, I have patients who have been traditionally very vaccine hesitant who are all ready to get the COVID-19 vaccine. So, and then when I try to ask if they will consider the other ones, they're like, no, just the COVID-19 vaccine. So again, it's sort of interesting, complex and complicated issue as to why a patient may be vaccine hesitant. And so one possible cause of vaccine hesitancy is actual needle phobia. And so this is known as trypanophobia, the extreme fear of medical procedures in the setting of injections or hypodermic needles. It affects up to 10% of the population, which is much higher than I realized. And it was recognized as an actual diagnosis, a specific phobia in the Diagnostic and Statistical Manual, DSM, in 1994. So I believe this is DSM-3 or even 3R, several iterations ago. And I think there is not only the concern of the needle phobia, but also the additional concern of patients altering health behaviors as a result. So not going to the doctor because you're afraid of getting a shot or needing to draw blood. And so then once those behaviors start, we now see how individuals with needle phobia may have worse health outcomes because they won't get their cholesterol checked or they won't go to the dentist and things like that. And then we've also seen in patients with needle phobia that can lead to more generalized fear of medical or dental healthcare providers. And so it starts with the fear of going to the doctor because you might get a shot, and then it just generalizes to being afraid of healthcare in general. So we started an intervention at UCLA a few years ago that I'd like to share with you. And the needle anxiety program developed out of a recognition that many of or actually my IDD patients did not receive their recommended medical services because of needle phobia. So these included not getting immunizations, not having their routine screenings for diabetes or cholesterol, or even not having the recommended blood level checks for medications such as seizure medications. And that can be very concerning if we don't get the right levels of the seizure medications. They're too high, too low, but without being able to draw blood, we have no idea of knowing it. I was actually quite astounded at the number of patients I had who were put on seizure medications by their specialist, and because of their needle phobia had never had blood levels checked, and I was concerned about that as their primary care provider. So at UCLA, we had no official policy on what to do with these patients. The unofficial policy was to take them to the main laboratory in Westwood, and there would be enough people to restrain the patient. And I was kind of horrified when I found out that that was our unofficial policy, because I find that very undignified for my patients, but also not safe for the healthcare workers restraining the patient. So that just did not seem like we should keep that. We needed to change that. And when I informally surveyed my colleagues, other primary care physicians, they seemed a little okay with deviating from the standard of care to accommodate the needle anxiety. I remember one internist who told me, well, the official recommendation to follow up a patient with diabetes is to check their blood every 3 months, but it's probably okay to just do it every 6 months or once a year. And I found myself saying, but if the recommendation is 3 months, why would we change that for our needle phobic patients? And so I set out to try to do something. So some ideas in my journey to figure out what to do, I went to the emergency department because they were really good at drawing blood or doing procedures on patients who were needle phobic. And I said, if I have patients who needed vaccines or blood draws, could I send them to the emergency department and you could do them for me? And they basically said no, because in the emergency department, the patient volume is difficult to predict and manage, and they couldn't anticipate, they said my patient might have to wait for hours until somebody was free to do that. And then I turned away from the emergency department, and I thought, there are anesthesiologists in the same day surgery centers, and could we just develop a mechanism where a patient who needed a blood draw or a vaccination could go to see an anesthesiologist, because they're also very good at this. And I was also told no, because then in a same day surgery center, they would get a bill for the operating room charge, because they would be there basically in a surgery center and they couldn't just not use the resources, not charge for the resources used. So even though they would be willing to do it, it would cost too much to my patients, and there was a chance that the insurance companies wouldn't cover that cost. So I said, okay, that's not going to work. So I wanted to just clarify the difference between moderate sedation and procedural sedation, because we're talking about procedural sedation. So moderate sedation used to be known as conscious sedation. So this is sort of the type of thing where you receive sedation because they may need to set a broken bone, or they may need to do stitches or sutures for a laceration, or in a child more so probably. And then, or like if you are needing routine colonoscopies and you receive a little propofol, so that's a common medication for conscious sedation or moderate sedation, you have a depressed level of consciousness, you are responsive to verbal commands and physical stimulation, and your breathing and cardiovascular functions are usually not impaired, but the medications used can cause respiratory depression or decrease of your breathing. And so it does require monitoring by a nurse. So it's a little more intensive. This is something that's over a couple of hours. And so for a vaccine or a blood draw, that's probably not really feasible. But procedural sedation, or also known as minimal sedation, there's no effect on breathing or cardiovascular function. And you may have some cognitive or coordination function, but you're able to respond. And procedural sedation would be something like nitrous oxide in the dentist's office, or, they used to use like a Versed lollipop for kids, or what we're using, inhaled Versed or midazolam. So procedural sedation guidelines have existed since 1985 for dentists and some pediatricians. And in October of 2014, the American Society of Anesthesiologists recommended new guidelines to allow expansion to other specialties. So they recognized the need for mild sedation, and it started to be used in emergency medicine at that time. And so our needle anxiety program is an adaptation of an emergency medicine protocol to be used in our urgent care clinics, which would make it much more accessible. So at UCLA, we're fortunate to have higher level urgent care clinics called the Evaluation and Treatment Centers. And the original mission of these urgent care clinics was to keep patients out of the ER and the hospital. So they're staffed by primary care physicians and RN level nurses, which means that they can, give IV fluids, IV medications, do higher level nursing functions that prevent patients from having to go to the emergency room. So after exploring all these other parts of the health system, the only place that I could base this needle anxiety program was the ETC. So after some, discussion with a committee, and a committee focused on creating this needle anxiety program, which included actually a psychologist who was experienced in procedural anxiety, we decided on a 3-tiered approach. So it's not that we wanted to go straight to inhaled midazolam or Versed for all patients that have procedural anxiety, but we wanted to try to address procedural anxiety in as many of the population as we could. So on the bottom, the orange part of the pyramid is what I call tier 1. We just needed better training for our medical assistants on how to approach needle phobia. So teaching our medical assistants, who usually give most of the vaccines, to not say it's not going to hurt, because for patients who are needle phobic, they immediately can have a sense of distrust because they know it's going to hurt. So when the nurse says it's not going to hurt, it sort of undermines that relationship. And so the first tier was just to have all of our medical assistants have better training. And so that has been something we've undertaken over the past year through one of our immunization quality improvement initiatives. The second tier is anything before we have to get to procedural sedation. So EMLA cream, which is numbing cream, a Buzzy Bee, which is this vibrating device that we keep in the freezer, so it's not only vibrating but cold. And if you put it, kind of proximal or like near the place that you're going to give the vaccine, oftentimes it's so numb that they don't feel the needle go in. So, techniques like that, or even a distraction video. We have a video that we show patients to teach them how to do deep breathing during the procedure, or they can just watch a video of their choice to take their minds off of what's going on. So those are all non-medication approaches to needle anxiety. And then finally, there's that small population of needle phobic patients who may require the inhaled midazolam. So this is our procedure, the protocol. It took us 2.5 years to get this approved. So I think I started looking into this in the summer of 2017. And it has gone through, I can't tell you how many committee meetings at UCLA Health. So first we had to get the departments of anesthesia and medicine to sign off on it. And this protocol kept coming back because they'd make a change and it'd have to go back and get sign off. So many levels of approval. And I have to admit the biggest hurdle was ambulatory nursing. So nurses in the hospital and emergency room are used to doing this type of procedure and using these medications, but nurses in the outpatient setting or primary care office are not. And there was a lot of anxiety among the nursing staff, a lot of pushback, a lot of training that needed to be had. And so this was a very large task, and I have to thank everybody who helped support me in getting this passed. But I'm proud to say that 3 years after starting the process, in August last year, 2020, we started it on 2 patients on the same day. So the first patient was a woman in her 30s that just had needle phobia, and she came in and it was fine. A second patient was an 18-year-old with IDD who was minimally verbal, and he was, actually his family drove from 2 hours away to be able to receive this procedure in order for him to get his blood drawn and get his vaccine, and it worked like a charm. And we have successfully used this intervention in about 12 patients to date, so it's not a huge number. It's a couple of patients a month. And so we're extremely happy to be able to not have to send these patients to the main lab to be restrained in order to get their minor procedures. So our next steps are to continue to track our outcomes and refine our protocol. Already in the last 6 months, we've realized that the doses that the anesthesiologist recommended were on the high side, that oftentimes, so right now, for example, the anesthesiologist recommended 2 sprays of the inhaled Versed, 1 in each nostril. And we found that even with just 1 spray, it would be enough. So half the dose. So one amendment to the protocol was to allow for a little bit of ramping up of the dose and not having to give the dose all at once. We also want to disseminate this to our other evaluation and treatment centers within UCLA Health. We have 3, but there is currently only in the first one, Santa Monica, which is in the middle of the county, and we have one in the south part of the county and one in the north part of the county. So we'd love to be able to provide it in all 3 locations. We still need to develop better training materials for nurses because they're still incredibly anxious about doing this procedure. And I have one who's wonderful at it and she understands and believes in it. And I have others that are very reluctant to do it. And then finally, we're going to raise awareness among the providers at UCLA that this service is available. We've sort of told our friends, meaning like neurology and genetics, because for our IDD populations, we often recommend genetic testing, and that requires a blood draw. And so, you know, the specialists who work with us with our patients are aware, but then when we have solidified the protocol and the procedures, we want to raise awareness among all providers at UCLA. So thank you for your attention, and I'm happy to entertain any questions.
Thank you, Dr. Kuo, for a great presentation and definitely very timely. So we will start with questions. If anybody has any questions, you can put them in the chat box and we're happy to go through and answer them. And in the meantime, I'll also drop a link in the chat box for a survey to give some feedback on our webinar. This is our monthly webinar series, so we'd love to hear from you on the webinars that we've already done, and then suggestions for future ones as well.
So I see questions starting to come in. The first is it possible for other states to use this protocol? So I have shared it with people who have asked me for a copy of our UCLA protocol. I believe that you'll have to go through all the issues at your own institution, right? So as I mentioned, there was a fair amount of work trying to get buy-in and to get people to understand that this was an important topic. And so I don't think it's an issue of the state. It probably is more an issue of the individual health system. So I'm happy to share the protocol because maybe it would jumpstart the conversation at other health systems to be able to see that a place like UCLA Health adopted something like this. And it may save some time off of the 3 years that it took me to get this implemented. Another question, is needle phobia only associated with a person seeing the needle? I know of a person with ASD who is blind and restraint is the only support she receives. I think that it depends. You know, I don't know. It's very interesting because I have a son, a 12-year-old, who is a bit neurodivergent, who also has significant needle phobia. It's not necessarily even about seeing the needle. Like I think it's actually an anxiety response because he in his head knows that it's a teeny tiny needle and it feels like a mosquito bite and all of this, and just observing over the years his challenges with needle phobia. It's almost an irrational fear, but it's a fear that they cannot control. So I think that it can manifest in many different ways, whether it is, you know, seeing the needle or just knowing that it's coming. Oftentimes, parents will report to me that it's not about the needle, actually. It's just the fear of it or the anxiety surrounding it. Were certified child life specialists involved at all in the decision of effective intervention? Yes, actually, they were concerned about the use of a medication and obviously would advocate for non-invasive interventions. However, they recognized, and I think one of the reasons we added the different tiers on the pyramid was we wanted to make clear that the inhaled midazolam, or the inhaled medication, was a last resort, that we were going to try to address needle phobia or needle anxiety in any other way other than the medication. And so there was definitely advocates for making sure that it wasn't that we were going to over-medicate and use this too widely. Yes, these have been used with patients with autism, and they were effective. The hardest part, I think, is actually getting the spray in the nose. So sometimes the process, technically, if the patient comes to the clinic and we're able to give them the nasal spray because the other techniques have not worked, then it should take 10-15 minutes to both have the onset of the medication and complete the shot, the vaccine, or the blood draw. However, sometimes the patient is in our clinic for up to 45 minutes or an hour, and most of that time it's actually figuring out how to get the spray into the nose. So from the Q&A, I see, have you considered expanding the system statewide or nationwide? That's sort of the purpose of this webinar. I think I wanted to see who was interested, if this seemed like it filled a need in the community. I do think that many health systems have the unofficial policy of the lab that will be able to restrain a patient in order to get needed studies. I'd like to put out there that perhaps we should recognize that that is not allowing our patients to have very much dignity and self-determination, quite frankly. And so expanding the system statewide or nationwide, I think it's more about disseminating this idea and helping individual health systems to adopt this kind of a policy. Other than training, have any other environmental modifications been considered to reduce anxiety? Absolutely. So as I mentioned in tier 2, the part where we use non-medical intervention. So other than training, the EMLA cream, if the needle anxiety is truly due to the sensation of the needle entering into the skin, then numbing the surface of the skin obviously would address that issue. So both numbing cream and the Buzzy Bee device, both of those are ways to numb the surface of the skin so that the patient does not feel the needle going into the skin, the injection itself. So that's one, when the issue is the actual prick of the needle. If the needle anxiety results from just the anxiety or the fear of the idea of getting a needle, an injection, then the other techniques like distraction, we have, again, a psychologist who is experienced in procedural anxiety that will sort of talk patients through their anxiety and be with them, and that additional support is sometimes enough to overcome the anxiety. So we definitely try other techniques before getting to the inhaled medication, and that is at the urging and with the participation of, for example, as mentioned previously, the child life specialist and the psychologist. Do you have a brochure or short briefing that we can share with our healthcare administrators? Not yet, but I think as part of our ARP primary care node, we're happy to put that together. Honestly, this is just something that I did here at UCLA, and I wanted to see if it would be useful to others, but if there seems to be, interest, we can definitely put together a package that will make it easier to disseminate throughout our ARP network. Are there videos or social stories geared for IDD regarding the COVID vaccine? This is a really important point, and I'm glad we're getting questions referencing that part of the presentation. So here in Los Angeles, so I'm going to share some information and then say we definitely need to do this. So here in Los Angeles County, we've had the rollout of the vaccine now for about 2 months or a little less than 2 months. And what we're seeing is already sort of disparities. So even though Los Angeles County is a non-majority county, which means that there is no ethnicity that is more than 50%, what we see as far as who is receiving the vaccine in Los Angeles County is that white members of our county are getting the vaccine at a rate of 2 to 1 compared to our Latino and Black populations. And so understanding that there is a component of vaccine hesitancy as well as vaccine access, the Department of Public Health has partnered with our local academic partners, so UCLA, as well as the University of Southern California, to try to address the vaccine hesitancy. Number one is allowing the vaccine to be distributed directly in the community so that they don't have to, for example, go to Dodger Stadium, which many people have heard about. And then the other is that a lot of the information was not available to them in their language or in their in their culture, the way that they would receive these messages or information. And so I think that with our IDD populations, we do need some targeted messaging around the COVID-19 vaccines, because I think many of our patients are in sort of the intersection of being a member of the IDD population, but also having either low income or being from a minority background. And so I think we do need to try to tailor messages and make them more accessible to these communities, because I think there's a lot of misinformation out there about the COVID-19 vaccine. I've heard people be afraid of it because they think it will cause them to, mutate their DNA. I've heard so many rumors that it involved nanotechnology that will somehow turn against you and your body. There's a lot of misconceptions. I'll just say both of those are not true, but those stories and those rumors are out in the community. And so when there is so much misconception about the vaccine, I think it really does behoove us to clarify messaging to our IDD populations, and maybe from trusted sources. So, identifying where those populations want to receive information and then partnering with those sources to be able to distribute and disseminate that information, I think would be really crucial. Have you experienced vaccine hesitancy from those who may have had a severe adverse reaction in the past and have made an informed decision not to take a vaccination due to this adverse response? So again, no vaccine is mandatory. Even the COVID-19 vaccine is not mandatory. And so when I have patients who, I wouldn't say that this scenario would be vaccine hesitant. I think they have just decided not to take the vaccine. So to me, they have just declined. They're not taking the vaccine. And if the patient has made that decision based on their previous experience, I have to admit I don't really push, because each patient can make the decision for themselves. So vaccine hesitancy is really about patients who have questions, who are not sure, or for whom the reason not to get a vaccine is like an external issue. Whether it's the needle, whether it's the, whether it's the anxiety, so to speak.
I think there might be one up above, Dr. Kuo. Are there any procedures for patients who are resistant to inhaling the spray?
Oh, that's a good question. So, I do think then later on there was a comment about using oral medication. So some parents have done that as well. And, in some cases, we've had patients who the parents said it would be difficult to even do the nasal spray. So we did prescribe, for example, a small dose of oral Ativan. And sometimes by the time they took the oral Ativan to come to the office to get the nasal spray, they were relaxed enough that we didn't even need to do the nasal spray. So I think it is very, it is a situation in which you can't rush things, and you have to be, everybody involved needs to be open to the fact that it may not happen that day. And so I think when the approach to either giving the vaccine or doing the blood draw is much more of one that we want to make sure that everybody is comfortable and that nobody is being, pushed or forced or hastened or rushed. Then I think the entire experience is much more pleasant and much more acceptable. And I think it's just much more dignified for our patients.
There's another question, but I also want to direct people's attention to the chat, not surprisingly, because AUCD always has really helpful information, but Don Rudolph included links to two different resources, one from the Boggs Center on Developmental Disabilities in New Jersey that has a social story related to the COVID vaccine, and then another one from the Center for Dignity in Healthcare for People with Disabilities at the University of Cincinnati Center for Excellence in Developmental Disabilities. Sorry, that's a mouthful. They also included a social story and a fact sheet from them. And then there's another question, Dr. Kuo. If the caregiver accompanies the person with intellectual and developmental disability, can they also receive the vaccine, which could incentivize the caregiver to pursue it?
Yes, so that's very possible. So here in the state of California, I can't speak to all of the other states, but at least here in the state of California, caregivers of individuals with IDD were prioritized together with healthcare workers. So they were considered to be in the top tier of prioritization for the COVID vaccine. And I actually did have parents who were sort of surprised that they would be prioritized over their adult child who happened, to have IDD as well. But we did vaccinate the caregivers before we vaccinated the individuals with IDD, because at this time in at least Los Angeles County, we have not yet opened our COVID-19 vaccine to anybody below the age of 65. And so I do think that having the caregiver be eligible will hopefully help them consider vaccinating the IDD individual that they care for. I understand.
What you're reading now is a comment on being more inclusive with language, which I think is a good point and always something really important to think about who the wording that's used for describing it. So this fact sheet and the social stories might be helpful for all individuals, right? And not just IDD individuals.
Absolutely, I agree.
I dropped the survey link in the chat. Please feel free to add in more questions if you missed anything. I dropped the survey link in the chat one more time. I just wanted to be conscious of time as we have just a few minutes left, and then also remind you all that you can register for our next upcoming webinar, which will be using autism research to inform policy, which will be done by our colleagues at the Drexel University, and there's a link to register on the next slide, please, Anna. Thank you very much. And this will be Lindsay Shea, Ann Rue, and Paul Shattuck who will be presenting on that on Monday, March 15th at 4 p.m. Eastern, 1 p.m. Pacific. And there's a link to register, and you can use the QR code as well. I will drop the link in the chat as well to make it easier for you all.
Great. So I think for next steps, we'll take the interest in this presentation as an indication that we'll try to put together sort of a brochure that people can share with their own health systems, and maybe with a copy, of our UCLA health protocol as a sample. Let me just make sure that that's okay to share, but I think it's meant to be publicly available, so I'll just double check that. And then hopefully we can start a movement and just recognize that restraining is not the best way to do these minor procedures. And definitely in light of the fact that the COVID-19 is available and important for our IDD population, that if we can address this aspect of vaccine hesitancy, then maybe we can get more of our IDD population immunized.
Thank you everyone for attending the webinar. Thank you, Dr. Kuo, very much for the important information. So just so everyone knows, this webinar has been recorded and will be archived on the AARP website. I dropped the link in the chat, and please take a few moments to complete our survey. Thank you very much.